Good morning, and I would like to begin by thanking Dr. Miller for giving me this opportunity. It's really a great pleasure to be here today. And so I will, during my presentation, I will follow up on what Dr. Fabian said earlier this morning about the use of MRI for the diagnosis of multiple sclerosis. And then I will discuss with you some of the limitations of clinical MRI. And finally, I will present some of the modern MRI techniques that may help us to overcome some of the limitations of clinical MRI. But just to begin, a few words on how MRI works. And as Dr. Miller said, the introduction of MRI has had a huge impact on medical care, and this is, of course, shown by the award of the Nobel Prize in 2003 to two scientists, Dr. Mansfield from Nottingham in England and Dr. Latterburg from University of Illinois in the USA, who were the first one to develop the methodology to make MRI images from the human body. And so the MRI is not only a fantastic technique to image soft tissues, such as the human brain, but it's also, unlike other techniques, such as computerized tomography, is not associated with the use of radiations, and so is considered very safe. So the generation of image through magnetic resonance images takes advantages of the huge amount of water molecules in the human body. And as you can see in this is the chemical representation of a water molecule with a molecule of oxygens and two nuclei of hydrogen. And the hydrogen is very important for the generation of the MRI signals. So when the subject lays down in the MRI scanner, all the protons or hydrogen atoms in his head, in this case, they align parallel to the MRI scanner, that is a huge magnet. And when we start the MRI acquisitions, we induce the generation of radio frequency waves that change the orientation of our hydrogen protons. And when we stop the radio frequency waves, all these protons they return to the original phase, so they are again aligned to the major magnet that is the scanner, and by doing so, they release energy that we can detect, and through computer programs, we can transform in images. So now, moving to the use of MRI in the diagnosis of multiple sclerosis, as Dr. Fabian mentioned earlier, the hallmark of the disease, MRI is the most sensitive tool for supporting the diagnosis of multiple sclerosis that is based mainly on the history and clinical manifestations. And as you can see here, the hallmark of the disease is the presence of bright spots, or as we call hyperintense T2 lesions, on this MRI image that we call T2 weighted. The lesions can be widespread in the central nervous system, including the optic nerve and the spinal cord, but they can have also a site of predilections. For example, they usually develop around the ventricles in the center of the brain, or as you can see on this different, on this axial image, they develop in the corpus callosum. This is very typical for multiple sclerosis. Also, the shape of the lesions can be very helpful for the diagnosis, because if you can, you can see here, for example, the major axis of the lesion is perpendicular to the ventricles, and the shape is an oval shape, and that is also very characteristic for multiple sclerosis. The image that you see next to the T2 weighted image is called FLAIR, that stands for Fluid Attenuated Inversion Recovery. And in very simple word, what is characteristic of this image is that, as you can see, the signal in the ventricles is not bright, but is dark, and this is very helpful for a better identification of lesions around the ventricle or lesions that are at the junction between the gray matter and white matter. A subgroup of lesions that are bright on T2 weighted images appear dark on different images that are called T1 weighted images. And when these dark lesions are persistent, we call them black holes. It's a subgroup of, not all T2 lesions are dark on T1 weighted sequences, just a subgroup of lesions, and several histopathological studies have shown that these lesions are associated with more loss of tissue, both myelin and nerves. And moving forward, as you heard earlier again from Dr. Fabian, after the injection of a contrast agent, in our case the contrast agent is called gadolinium, we can see active lesions that become very bright. It's the contrast agents that goes through the blood-brain barrier that has been opened by the inflammation. And these gadolinium-enhanced lesions are more frequently nodular and more rarely can have this kind of appearance, so it can be ring-enhancing lesions. And this is usually attributed to the inflammation of the rim of chronic lesions. The spinal cord is a very important site of lesion localization, and so there are between 5 to 20% of cases where the lesions are present only in the spinal cord and not in the brain. And this lesion, 20% of the entire, almost 20% of the entire number of lesions develop in the spinal cord, and 60% of these lesions are usually in the cervical segment of the spinal cord. And these lesions are have very particular features. For example, they to be compatible with the diagnosis of multiple sclerosis, these lesions do not have to be longer than 2 vertebral bodies. They do not have to occupy, here you see an axial view, they do not have to occupy the entire cross-sectional area of the spinal cord. So they are usually located peripherally. So these sequences, the sequences that I just showed you that are part of the clinical MRI protocol are very useful for the diagnosis of multiple sclerosis, for an earlier diagnosis of multiple sclerosis, as you heard earlier from Dr. Fabian. In patients with clinically isolated syndrome, we can repeat an MRI and we can diagnose multiple sclerosis without waiting for a second clinical episode. And this allows us to start treatment earlier, and based on the evidence that the earlier start of a treatment is associated with a better clinical outcome. And as you heard also this morning, the number of lesions in patients with CIS is predictive of the conversion from the clinically isolated syndrome to clinically definite multiple sclerosis. And since also MRI is more sensitive to disease activity than clinical symptoms, because as Dr. Fabian explained this morning, not all lesions manifest in clinical symptoms. So only the lesions that are in certain areas that are very important for neurological functions will induce the presence of symptoms, but there are many more lesions. So the MRI is more sensitive to disease activity than clinical symptoms, and so is useful for monitoring disease progression, and is useful also for monitoring response to treatment. Despite all these advantages, there are some limitations, and one of these limitations is the lack of pathological specificity. And I will try to explain what I mean with pathological specificity. So we know from that the pathological features of multiple sclerosis lesions are very heterogeneous, and many pathological processes can be ongoing in the same lesions and in different lesions. For example, we know that some lesions are mostly inflammatory, so they are acute lesions, and there is demyelination, loss of myelin going on. In other lesions, there might be more remyelinations, and in others, there might be more loss of nerve fibers or axons. And regardless of all this heterogeneity, when we look at these images on our routine clinical T2-weighted images, they look all alike. They look all as bright spots, but all of them are actually in a different phase of evolution and with different pathological substrate. Now, another limitation of clinical MRI is that there is a tendency to overlook gray matter pathology. We know, we have learned in the last 5 years that gray matter, so the surface of the brain, is also affected by the disease, and lesions are not only present in the white matter, but also in the gray matter. But unfortunately, again, if you look at these images that are the clinical images, you cannot really see lesions, detect lesions in the cortex, in the gray matter. So here is one of the most important pathological studies that has shown that gray matter lesions are actually, even if we don't see them on common MRI scans, they are very common. And in this cartoon, you can see that the black spots that indicates lesions are present not only around the ventricles in the white matter, but also in the gray matter. So in the last 15, 20 years, there has been a lot of research to try to develop sequences, imaging techniques that can overcome some of these limitations. And there are really many sequences, and for sake of time today, I will just focus on the one that are highlighted in pink, so on double inversion recovery, measures of brain atrophy, diffusion tensor imaging, proton MR spectroscopy, and ultra-high field MRI. So double inversion recovery is the name of a sequence that has been developed to improve detection of lesions in gray matter. And what is, in very simple words, what happens in this sequence is that with particular computer programs, we are able to, as you can see, null out, to eliminate the signal from the white matter and from the cerebral spinal fluid. And so we can see just the gray matter, and this allows, this better delineation of the gray matter allows also a better detection, higher detection of lesions. Here is another example where you have a magnification of a lesion visible on T2 images, on FLAIR images and double inversion recovery, and you can see that it's very difficult to identify the lesions on T2-weighted images and FLAIR images, and becomes easier to see and detect the lesions on double inversion recovery. So why why do we want to detect gray matter lesions? Why do we want to see them? Well, there has been a lot of research that has shown that gray matter lesions might have a high clinical impact. For example, patients that progress clinically have a higher number of gray matter lesions, in the cortex, and the number of these gray matter lesions is predictive of, for example, of development of disability and development of atrophy or loss of brain volume. And also, we know that a certain percentage of patients with multiple sclerosis complain cognitive symptoms, but we really is the mechanisms leading to cognitive symptoms are not very well understood, and the presence of, we have learned recently that the presence of gray matter lesions might be associated with the development of cognitive symptoms. Now, moving to measures of brain atrophy. Brain atrophy reflects loss of brain tissue, including myelin and including white matter fibers, axons, and including also neuronal cells. And there have been several studies that have shown that brain volume changes are clinically relevant. They are associated with progression of the disease. And measures of atrophy are also, in addition to the measures of lesion count, are very often used in clinical trials to assess the efficacy of treatments. And what you can see here is the evolution of brain atrophy over 20 years of disease. And as you can see here, after 20 years, the atrophy is very evident because it's visible because of the enlargement of the lateral ventricles. And so in the past, radiologists and neurologists were able to detect atrophy only in the late stage of the disease when it was very visual evident. But thanks to technological advances, now we can, with high accuracy, we can measure atrophy since the early stage, brain atrophy, since the early stage of the disease. And we can quantify, and so it's not just a visual assessment of enlargement of ventricles, but is an objective quantification and can be used, and is a valuable measures used in clinical trials. Even more, thanks to technological advances, we are also able to separate the gray matter from the white matter and measure separately the volume of gray matter and volume of white matter. And we have been learning a lot of new things about the biology of the disease by measuring separately white matter and gray matter volume. For example, something that is new information that we have learned is that gray matter atrophy seems to develop faster than white matter atrophy and seems to be better associated with physical disability, cognitive symptoms, and with quality of life. Of course, we need to do a lot of more research because we are only at the beginning, and there are still a lot of questions that we need to answer and a lot of processes that we need to understand. For example, we don't know what is the relation between the damage in white matter and damage in gray matter. Gray matter damage might be the mere consequence of the transections of fibers in white matter lesions, or the injury in gray matter might be independent and concurrent to white matter injury. So moving to a more sophisticated sequence that you might have heard about, that is diffusion imaging. Just will say something about how diffusion imaging works. So Diffusion measures the movement. I told you that the majority of our body, 80% of our body, is composed by water molecules. And so diffusion is able to measure the movement of these water molecules in our brain. And unlike what happens in a fluid, the water molecules in a fluid, for example, water in glass, the water molecules can move freely in any directions within the glass. Now, if you look to the other cartoon, that is very schematically what happens in the human brain. So in the human brain, we have a lot of cells, a lot of fibers, a lot of membranes, and a lot of organelles. And so in the human brain, the molecules of water cannot move freely. Their movement is, we say, restricted by the presence of all these anatomical structures. And so whenever there is a damage of, for example, neurons or axons or nerve fibers, the movement of these water molecules will not be restricted, but will be more free. And we are able to detect this change, and so to indirectly detect a specific injury in the tissue brain. Just to give you an example of how diffusion images look, here you can see in first image is very similar to T2 weighted images, and the arrows are indicating two MS, white matter MS lesions. And here you can see a diffusion image that is called fractional anisotropy, and is a very nice picture of the organization of the white matter fibers in our brain. And you can see, for example, that these two lesions that are very similar on this image are actually different on the diffusion image. For example, this lesion is associated with a dark spot, and that means that that lesion is very severe, and the white matter tracts have been severed, have been transected. Instead, the pathology of this other lesion is milder, and there is no damage to the white matter fibers. And here, the color figures is just a color-coded representation of the same fractional anisotropy map, and the colors indicate the direction of the fibers. So red is for fibers that are whose direction is from right to left, green from top to bottom, and blue from the outside, inside of the image. Just another example of the information that we can collect from diffusion images. You can see here lesions, and if we reconstruct the white matter tracts in the lesions and in the contralateral white matter that appears normal on this image, we can quantify. For example, we can visually see that in the region where the lesion is present, most of the fibers have been transected. Instead, the direction and the presence of fibers contralaterally, where the tissue is normal, is also normal. Again, probably because we can collect more specific information related to the pathology of the lesions, we can also, these kind of measures are better associated, can better explain clinical symptoms. For example, the diffusivity over the brain has been found to be associated and to explain, at least in part, some of the cognitive deficits. Now, one more of this sophisticated technique that is called proton spectroscopy, and is kind of different from what I have shown you so far, because I told you that water is very important to make the MR images. Now, to acquire proton spectroscopy that allows us to measure brain chemicals, we need to suppress the signal from the water because the concentration of these brain chemicals is very low compared to the concentration of water. So to make them visible, we need to suppress the signal from water. And instead of an image, when we acquire proton spectroscopy, we see a spectrum where different chemicals have their own specific fingerprint. They resonate at a very specific frequency, and we can measure and quantify the specific chemical. And I will just concentrate on one of these chemicals that is called N-acetyl-aspartate, abbreviated as NAA. N-acetyl-aspartate is a chemical that is localized in neuronal cells and the nerve fibers, and so it's considered very specific for the integrity or injury of neuronal cells. And just to give you an example, we can collect, for example, spectra, chemicals resonance from several regions of the brain. And if you look at the NAA peak that has been collected from these MS lesions, and you compare this to the NAA peak of a region of normal brain, you can visually see, without any quantification, that there is a decrease of NAA that reflects most likely a decrease of number of neurons or dysfunction of remaining neurons. And finally, although you are probably used to MRI scanners that are in the range of 1.5 Tesla and 3 Tesla, that are the clinical MRI scanners, in the research field, the scanners with higher field strength, so 7 Tesla, that are used for research, are starting to give clinical informations. Tesla is the unit of measure of the field strength, and of course, when you go from 1.5 to 7 Tesla, the intensity of the signal becomes higher, and with this much more signal, you can see more, you can improve your spatial resolution, you can see many more anatomical details. And I will just give you an example. This is an image acquired from a patient with multiple sclerosis at 7 Tesla. It's a study that we did when I was working at New York University. And as you can see, is in addition to the lesions that are indicated by the arrows, you can see these little dark stripes that go through the lesions. And so mostly the majority of lesions develops, as we know from histological studies, but before now we were not able to see that in a living brain. Most of these lesions develop around small veins in the deep white matter. So in summary, we discussed the utility of MRI, clinical MRI, for the diagnosis, prognosis, and treatment response in multiple sclerosis. And then we discussed also other more modern MRI techniques that can be helpful for detecting, for example, gray matter lesions, or for detecting more pathological specific changes in myelin and nerve fibers and axons and neuronal cells. And of course, we have seen that by improving the pathological specificity of these techniques, we can better explaining clinical symptoms. And of course, the advantage of some of these techniques, they are not prime for clinical use. They are mostly in the used in the research setting, but they can provide information that have the potential to provide a more comprehensive evaluation of clinical disability and a better prediction of clinical course. And they also could help to better tailor therapies in patients with multiple sclerosis and help monitor response to treatment. Thank you very much for your attention.